अश्विनी मेरे को बंद करायला सांगतो तिला. Just a minute.
Over to you,
नंतर
sir.
बोलू शकतो.
Yeah. I'll take over. चालू करू मॅडम?
हो चालेल.
Bivas will start.
Yes.
Yes, sir. Please go ahead.
Thank you. Hello, good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room.
Yes. Good afternoon.
This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare has 25 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing four biosimilar products to market within 5 years of initiation. Today's webinar, Case Studies from Labor Room, we have got Honorable Speaker Dr. Tanuja Joshi Madam with us. Welcome, Madam.
Thank
Dr.
you.
Tanuja Joshi is MBBS MD, Diploma in ART, PGDCR from Symbiosis Pune and conferred FICOG. Madam is consulting gynecologist practicing independently since 1996 and currently empaneled gynecologist Aditya Birla Multispecialty Hospital, Surya Hospital and Sterling Multispecialty Hospital. Over to you, Madam.
Yeah. Hello. Thank you, sir, for introduction. But I would like to add one more point. I'm medical director at Srinivas Hospital. I'm a full-time gynecologist. That's my own hospital in Nigdi, and there I'm practicing. And our motto is ensuring tender care with tender hands to our populace. And I'm practicing since 1996 in Pune. That's all. We'll go ahead. Yeah. Next slide,
Lovely,
please.
Madam. We didn't know. Apologies. We didn't know this point.
No problem. No
Yes,
problem.
yeah.
We'll today have an overview of postpartum hemorrhage. Postpartum hemorrhage is a very dreadful situation which any obstetrician will face in their lifetime. And although with proper management of labor, the complications are rarer, but we have to conduct each and every delivery with precision and keeping all the complications which may happen, we must anticipate them, and our labor room is an armamentarium where all the facilities should be there. And we should have a tertiary care tie-up in case your hospital is not having ICU facilities and further management protocols. If they are not available, we must have this. So in this case, the different Manyata recommendations as well as the NABH checklist, that all has to be ready. The next slide, please. So each and every obstetrician knows that the average blood loss in a normal delivery is around 500 ml and around 1000 ml of cesarean section blood loss is expected. So this is usually a visual training which any obstetrician gets. And the obstetrician gets also the visual impression, which one is mild, which one is moderate, and which one is severe. But we must add to this our clinical judgment, and we must act a little bit beforehand. We should not wait the normal vaginal delivery blood loss to happen till 1000 ml or the normal cesarean section 1000 ml to 1500 ml or a 2 liter or more than 2 liters, because any actions taken at right time saves the life. So the action at proper time is must. So PPH, it is a common, it can occur in women, but in certain conditions, it is more common. And the maternal mortality, it is one of the leading causes of maternal mortality. So around 10% cases of maternal mortality are attributable to this thing, PPH. Next slide. So it is an unfortunate event in any female's life, because when the mother is lost, the whole family gets disturbed, the societal fabric gets disturbed. So it is our utmost duty as an obstetrician to give a mother a good obstetric outcome. So the maternal mortality I just discussed is a leading cause, and now the maternal mortality has come down to around 80 per 1 lakh live births. So that is the role of obstetricians and our healthcare duties, which has led to the less maternal mortality rate. So the PPH incidence over the period right from 2014 to 2024, it has reduced drastically, but still we have to reach a goal where no mother will be lost to the normal delivery process or a cesarean delivery process. So that should be our goal. Zero maternal mortality should be our aim. So we need to have more medications, more good setups for the antenatal care of the mother. Next slide. So we all know what is the postpartum hemorrhage etiology. So we must remember the four T's. First one is tone. Immediately after the delivery, we must ascertain the how is the tone of uterus. If you find the uterus is flabby, we need to do the immediate binomial massaging. You need to give some uterotonics. The second etiology is thrombin, that is coagulopathy. This can occur in few cases of abruptio placentae, a case of PIH, and all other things. In that, the coagulopathies are common. So, second factor is thrombin. The third one is trauma. The trauma could be the uterus, injury to the reproductive tract, genital tract. There could be uterine inversions, there could be uterine lacerations, vaginal lacerations, there could be paraurethral tears. So the trauma during cesarean also, like the angles, they may get extended. So all these causes can lead to postpartum hemorrhage. The fourth one is tissue, the retention of placenta, the retention of blood clots, and the abnormal placental implantation, that is accreta percreta category. So the four T's are important to be remembered as a cause of postpartum hemorrhage, that is stone, thrombin, trauma, and tissue. The next slide, please. So the clinical findings mainly we see by our eyes that there is an excessive blood loss. We palpate with the hands, and that is the tone of the uterus, as well as we see the clinical condition of the mother. So the clinical situation depends what type of blood loss is. Usually 500 to 1000 ml is a compensatory blood loss. Any individual, if she's having good hemoglobin levels, she overcomes that blood loss. And the symptoms, if the blood loss is little bit more, she will have palpitations, dizziness. Then we can see the tachycardia, pulse rate increases. There could be slight fall in the systolic blood pressure. So we can decide the clinical condition of a patient and whether she is deteriorating by the rule of 30. Like if the pulse rate increases by 30, that happens in severe, but we have to detect the like tachycardia from 80. If the patient is having 90% and it becomes 110, we must think after determining that the pulse ox is probe is at the proper distance, again rechecking whether actually the heart rate is that much, it has increased by 20 points or 30 pulses. So that watch has to be kept. Watch has to be kept on the blood pressure measurements also. So we should not wait till the parameters fall down to the extreme levels. Otherwise, it may be late to revive the mother. Next slide, please. So what should be the approach towards managing postpartum hemorrhage? Uh, I can say we should have one word as an acronym, that is homeostasis. If we see any patient of PPH, then we must ask for help. We must massage the uterus. We must use ergometries. We can say that ergobolics or uterotonics. If with these measures we cannot control the PPH, then we may have to go for stepwise devascularization, internal iliac artery ligation, or if O is that coagulopathy is present, then we have to manage by FFP, PCVs, and platelets, whatever type of the patient is having values. Like we measure BTC-TPT, fibrinogen levels, and all those things help us to manage the patient. And in case of poor uterine tone, we usually manage with the massage. Then the other alternatives are oxytocin that we routinely give in the management of third stage of PPH to prevent PPH, third stage of management of labor. Then, according to the patient response, we modify the treatment. Uh, Sometimes the atony is associated with the trauma also, genital tract. So we have to consider that also. Like the uterine tone is recovered, but still if the patient's hemodynamic stability is not there, then we should look for the trauma at the vagina and cervical tear or something, if that possibility has to be thought of. Then retained tissue, if we find any retained placental tissue, we can do manual removal of placenta at the same time. Or if a patient is of increta percreta, but nowadays, as the most of the patients, they are getting proper antenatal care. So these conditions are usually diagnosed antenatally. And if it is there, this condition of accreta percreta increta is there, then the patient has to be managed in the institution, and accordingly, all the mm, readiness has to be there. Next slide. Next slide, please. Yes. So, the different uterotonic agents, they are oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Usually, I give methargine, carbetocin at the delivery of, after the delivery of baby, or at the delivery of placenta. The prophylactic use is best for prevention of PPH and active management of third stage of labor, and that can be used oxytocin and oxytocin and methargine. They can be used, as well as prostrodin can be used in the. They are used in management of PPH, but carbetocin is used for prophylaxis. The previous slide. Previous slide. So the rationale for development of carbetocin, why there was a need for a different new molecule. The oxytocin is a heat labile molecule. It needs refrigeration. The cold chain needs to be maintained. And because of this, sometimes the oxytocin molecule loses the potential. And when used, you may not get the expected results in the management of PPH. So, the advantage of carbetocin over the previous molecules is it is stable at room temperature. It has got a long shelf life of 24 months, which can be preserved at 30 degree, and it avoids cold chain storage and logistics, and it is provided in a vial, and it is cost effective. We can always use this, like instead of landing in the complications and going for stepwise devascularization or internal iliac ligation, we can always use this molecule. It is not that costly that patients cannot afford or the hospital cannot afford. The next slide and the next slide. Next slide. Next slide. So carbetocin, uh, previous slide. Carbetocin was created making several modifications to the oxytocin structure. So because of this modification, it prolongs its half-life and reduces enzymatic degradation. And basically, it is used for prevention of postpartum hemorrhage due to uterine atony. It comes in a vial which contains 100 microgram of carbetocin, and it is a 1 ml vial. Next slide, please. Next slide. So we can compare between the oxytocin and heat stable carbetocin. Oxytocin is a synthetic cyclic peptide form which naturally occurs from the posterior pituitary, and everyone knows that it binds to the oxytocin receptors, it stimulates the contractions of the myometrium, and thereby it increases the contractility of the uterus, and it avoids the further loss from the uterus. Whereas carbetocin, it is a long-acting synthetic analog of oxytocin with agonist properties. This too binds with the oxytocin receptors, and it gives a strong rhythmic contractions. And the advantage is that it has got a longer half-life. The action starts within 2 minutes and it lasts for almost 60 minutes if you give it by intravenous route. This can also be given intramuscularly as similar to the method we use in oxytocin. Only thing, it cannot be used in drip. Usually we give it IV as a bolus slowly over 2 minutes. Then the storage, I will just discuss that it is this carbetocin is stable up to 30 degrees centigrade, and this needs storage. The clinical indications: prevention of PPH is the main aim of carbetocin, whereas oxytocin can be used in all the indications like induction, augmentation, prevention of PPH, and treatment of PPH. So it has got multiple uses, whereas carbetocin is focused mainly in prevention of PPH, and the facilities where all other facilities are not available for surgical things immediate. So the carbetocin has got main role in such institutes also, as well as the bigger institutes also. So we can adapt to adjusting or accommodating carbetocin in our obstetric management of third stage of labor. Next slide. So what are the clinical evidences? Like many clinical trials has been conducted by who? The famous is Champion trial. So there are around 30,000 women across 10 countries, including India, they were studied, and the effectiveness and safety of investigational carbetocin to oxytocin in prevention of PPH was studied. So the proportion of women with blood loss of at least 1000 ml, it was seen, and it is found to be effective in this study also. The next slide. So the frequency of blood loss and the use of additional uterotonic agents with carbetocin was proven non-inferior to non-inferior versus oxytocin. The use of additional uterotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. It suggests that both have got the equal action, but the major advantage with this molecule is it is heat stable. So these are the advantages which we can take in our practice. Next slide, please. The Cochrane review is carbetocin for preventing postpartum hemorrhage. So again here some 2,635 women were included. There were 11 studies, and the author of the study, Cochrane review, concluded that women who undergo cesarean section, carbetocin resulted in a significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometry in the prevention of PPH for women who have vaginal deliveries, and is associated with significant fewer adverse effects. Next slide. The guideline recommendations are: who has kept it as second line, oxytocin, carbetocin. The Canada Society of Obstetrics and Gynecological Society has recommended it as the first drug of choice, 100 carbetocin, 100 microgram IV as a bolus. The other countries or the associations which have adopted carbetocin is FIGO. It is one of the recommendations for PPH management, as well as Germany and France obstetric gynec societies, they have included this. So I think we should also open the armamentarium of our management or medications in the management of PPH as a carbetocin. It could be a very precious tool in preventing PPH, especially the uterine atony. The traumatic and other factors we have to manage clinically after identifying the cause, but the uterine atony is the commonest factor which we come across. Next slide, please. So, my experience with carbetocin is that I am using it in both cases. I have used in normal as well as cesarean. I have found the good results uh, uh, where the Carbetocin was used as a result drug. There also I found a good results. And whenever it was required, like whenever I have used carbetocin, I have found that I don't have to resort to the surgical this thing, surgical intervention. And I have used it tween pregnancies, polyhydramnios cases, where there is a risk, or in cases of other things we can say like mainly tween and polyhydramnios I have used. And the indications we can say for carbetocin, they are the same what we do in a normal uh, management. Like wherever we are using carbetocin, we can use it except induction and augmentation. And the effects are really very good. We can use it in PIH cases also, even anemia cases also I have used. I didn't find any like significant rise in blood pressure or any like heart rate increase in anemic patients or any discomfort. I have not found it. And I found it good, like with no side effects. And I can rely on this molecule. The next slide, please. I'm using it for last 3.5 years. I use it approximately 80% cases of deliveries in prophylaxis, and I found action is longer than oxytocin. And just describe that indication, contraindications. They're almost similar to oxytocin. We can use it in Rh negative mother also, but the principles are same. After the delivery of placenta, we can use it. Yeah. Next slide, please.
मॅडम इनफॅक्ट यू आन्सर्ड मोस्ट ऑफ द पॅनल क्वेश्चन्स बट विल जस्ट रन थ्रू द क्वेश्चन तुम्ही सगळ्यांची उत्तर ऑलरेडी दिलेली आहेत व्हॉट इज द बेनिफिट ऑफ कार्बेटोसिन युझिंग कार्बेटोसिन एज अ फर्स्ट लाईन in every pregnancy as
Yes, it
prevention
has
of
got
pregnancy.
a faster action,
Yes,
prolonged action, and if it is kept in labor room at the and if it is given right at the moment, at the correct moment, like the
correct,
after the delivery of baby or
correct,
the placenta,
correct,
we get very good results,
correct,
and there is a significant reduction in the blood loss also. So
correct,
it is a good molecule. We can use it as a first line drug to prevent PPH.
correct. Madam, although you have described the patient profile who can get PPH, how common is
Yeah.
anemia and how common is anemia related PPH?
Like anemia will not itself lead to PPH,
Uh,
but the individual or a pregnant woman who
yeah,
is having low hemoglobin levels
yes,
will
yes, yes,
not withstand postpartum hemorrhage
correct.
quite well. So
Correct,
a mild PPH will be considered as a moderate PPH for
moderate,
anemic patient,
correct, correct.
and the moderate PPH will have to be managed as a severe
Severe
PPH.
PPH.
So that is the difference which we have to judge clinically. So the patient profile I just discussed, multiple pregnancy, polyhydramnios, abruptio placentae, or a PIH case, all these cases, we anticipate more risk of postpartum hemorrhage.
Now coming to anemia, now you are practicing in a good area in Pune. How common is anemia in that area, in the area where you are practicing?
Yeah, it is quite prevalent. I see almost 30 to 40%
Oh my God.
pregnant women who are having hemoglobin at between 8 to 9.
Acha.
Rarely I can find around 11. That
Okay.
too, I think even good class
Yes.
antenatal mothers, they too are having less hemoglobin. It might be related to the fat food which they
Yeah, yeah,
usually go,
yeah, yeah,
especially IT crowd. They don't have time. Most probably, that is what they say. We don't have time to look after us, and they do not concentrate much on diet.
correct,
And
correct.
because of that, sometimes in good economic strata patients also we find anemia.
Absolutely.
So the correction of anemia is the basic step which I will
Absolute,
recommend,
absolute,
and the proper
absolutely,
antenatal care,
absolutely.
detection of the PRH at
Yes,
proper time,
correct,
all
correct,
these
correct.
things. Then the diabetes will give macrosomia.
Mm.
So affluent population, they have got this gestational diabetes mellitus has become very common
Correct.
because of the lifestyle issues and the diet is not properly followed. And because of that macrosomia, polyhydramnios, that too have become more frequent compared to the previous
Earlier
years of
times.
my
Earlier
practice.
times.
So the PPH is also common in this
Correct.
antenatal mothers, I can say.
And I mean, this may be a very, I'll say a simple or silly question. Has PPH got anything to do with economic strata?
Economic strata, I can say, yeah, true. Low socioeconomic uh, females, they will have more PPH because they are having low hemoglobin levels.
Correct,
Because
correct,
that is
correct,
very more common.
correct.
But as such, I will not say that PPH is common in this because they lack proper antenatal care,
Yes,
and
yes,
because of that, they cannot withstand the
correct.
hemorrhage. Even in other case, it may be considered as normal, but because of her uh, cardiovascular status,
Yes, yes.
it can be labeled as postpartum hemorrhage for that particular patient. And in affluents, I just told you that the PIH is also elderly
Yeah, 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 yeah.
gynae, that is giving rise to the higher blood pressure because of the
Correct.
late marriages.
Yes, yes,
We
yes.
encounter more pregnancy-induced hypertension in such cases. So that because of that PIH, we also entertain the PPH because the same criteria applies to the
Correct,
PIH also.
correct.
The blood loss, however small, is significant for the
Yes,
severely pre-eclamptic mothers. So it is the condition, clinical
condition.
condition that is
Yes.
making them more prone to PPH.
Thanks, madam. I mean, you already answered this. This also you have answered. You generally prefer IV route or IM route, madam?
I have given IV only. I
IV.
usually prefer IV, but it can be tried IM because
IM also. Yes.
if it is like a particular hospital can decide their own strategy. If
Protocols.
they are
Yes.
having people like usually during labor, we usually take a IV line.
Correct.
So the dilution and everything, in case any anaphylactic reaction, we are
Yes.
prepared. So
Yes.
I and IV route has got a faster action.
Faster
So it
onset
is
of
better
action.
to have. Basically, we
Yes.
are using it for prevention.
Yes.
So prophylaxis. So it is better to give IV. Why intramuscular? We can
Correct.
give, but IV is the better route. That is what I think.
And your experience, how well it is tolerated? You have been using for quite long. So how is it tolerated? Any adverse effect?
Yeah, I haven't seen any patient who had any significant complaints. They have tolerated well. They have
That's
tolerated
wonderful.
well. Up till now, I haven't seen any problem.
That's wonderful. Suppose if the patient is not adequately responding adequately with carbetocin, then of course you would use other drugs. But order of preference, your order of preference.
Yeah, I will be using after carbetocin, prostaglandins,
Uh,
PGF2 alpha, 15 methyl PGF2 alpha, and misoprostol if required.
that's
But after carbetocin, if patient is not responding, I will have to keep a close watch on her. Close surveillance is
yes,
required
yes,
in
yes.
such cases.
And then
Although I will
physical.
be using some alternative,
Yes.
and I usually continue oxytocin infusions
Correct, correct, correct.
for next 4 to 6 hours post delivery. I always check 1 hour after the delivery how is the fundus of the uterus, whether it is contracted, any significant blood loss is there. So secondary PPH also gets detected, and in that case we can repeat the, if we find that there is a secondary PPH, keeping our mind alert, we can
Hmm.
repeat the carbetocin at that
Yes.
time.
I suppose the major advantage is you don't require a storage conditions. I mean, those refrigerator and
Yes, yeah, that is the main
major
advantage
advantage. Yes.
because we don't lose potential
Yeah,
molecules
potency of the drug.
potential.
Yes, yes, yes. And power outage is common everywhere in India today. I mean, even in Mumbai, we have got very common power outage. So the refrigeration and the way they are transported drugs, it's better they have to
Yes.
use this place.
It can be like
First line.
I I can give like it depends on the obstetrician's facilities which a obstetrician is having.
Hmm.
So they can decide whether it can be used
That's
as a
true.
first line or a resort drug, but it can be used as a first line drug because it
Yes,
has got an excellent results.
absolutely.
So it can be kept as a first line drug.
And finally, to conclude, what is your overall experience, take home message to be precise? Lokana, take home message.
Take home message, we must try always something new. There is always a fear for new things, but unless we use it, we will not gather the information, we will not have the experience. So, using the past experiences of the persons or of the doctors who are using these molecules and attending such webinars, we can get like some information and we can also try. So, the new people who have never tried, can try. I think it can be tried and they can gather their own experiences. So the fear of unknown or fear of new things
Yes,
should not
yes.
be there and we must try.
Correct.
If it is like proposed by like certain researches
Yeah.
or like usually if there is any molecule like few hospitals, the Indian studies are also conducted. So if
Yes.
they are favoring, if our association is favoring and few local doctors, those who are like having good practice and if
Correct.
they are recommending, we can always try. So that is a take home message, like
Take
we
home.
should not resist any new
Correct.
molecule. We must look into what are the advantages and disadvantages of it and the cost effectiveness. So based on that, you must decide. One must decide to use that molecule. So you open to the molecule. You be open to the molecule.
Correct.
Yes.
Madam, thank you so much, madam. Thanks for
Yeah.
sharing your experience. In fact, this is
Thank
experience
you.
what our participants want rather than reading theoretical literature and references. Thanks once again for sharing your experience. I'm sure it will give them confidence to use the drug further. Thank
Yes.
you. Thanks for your time today afternoon.
Yeah.
Thank you.
Thank
Thanks
you.
all the doctors who took time and attended this session. Thanks marketing sales team of Wipro. Thanks IT team, Sai Srikar. Thank you so much. Thanks all of you. Madam, you can log off. Wish you
Yeah.
a very
Thank
pleasant afternoon and a happy weekend. Thanks,
Thank
madam.
you.
Thank you.
Yes.
Thanks, Sai Srikar. Madam, log off.
Thank you, sir. Happy weekend.
Thanks, Bivas. Thanks, Sai.